Nice purple background.
I changed it. I had it green this morning. Oh, okay.
So we forward the slides for you.
Yep. Okay. All right, so just because we're starting the new year, I thought it would be important for us to kind of revisit the initial hepatitis C evaluation. We also have a lot of new providers on here too, so this hopefully you guys can all learn something from today's didactic, and we can answer questions at the end. Go ahead and go to the next slide, please. So the objectives today, I want to just briefly review what the current HCV screening recommendations are, differentiate between acute and chronic, how to obtain, a good patient history with risk factors, what to educate your patients on, just kind of bring up some of the clinical manifestations that we see with hepatitis C, importance of assessing for fibrosis and HCC screening, assessing for cofactors of disease progression, what we order first visit typically, also just a brief slide on hepatitis C and pregnancy, and then our discussions as far as what to expect from a patient's expectations as we're planning for treatment. So HCV screening, there's actually currently varying recommendations on who should be screened for hepatitis C. And in West Virginia particularly, just because of this injection drug use and opioid epidemic that we're battling, I would recommend, we're really testing all adults for hepatitis C, but the AASLD and IDSA hepatitis C treatment guidelines recommend one-time routine opt-out HCV testing for everyone over 18, and then risk factor based if they're under 18, and then annual testing if there are ongoing risk factors. Now, CDC still has the risk-based testing approach, and then they also have routine testing for our baby boomers, so everybody that's born between 1945 and 1965. The United States Preventative States Task Force is also pretty consistent with that risk-based approach, but they actually have a draft in place, a summary draft statement in place that they are planning to hopefully expand it to all adults between age 18 and 79, which will be nice because then as far as if that's approved or becomes the new recommendation, then that test should be paid for by insurance if it's not already. So that's kind of where we're at. Risk factors, we break it up into risk behaviors, injection drug use, intranasal drug use, and then considering also men who have sex with men, particularly HIV infected men who have sex with men. Risk exposure, so if a patient's ever been on hemodialysis, if they had any blood or transfusions or even organ transfusions before 92, clotting factors administered before 87, history of incarceration, history of percutaneous or parenteral exposures in an unregulated setting, so including, tattoos, jail tattoos, home tattoos, buddy who's a tattoo artist but did it at home. And then also consider testing your veterans. So there's especially during the Vietnam area where many of the veterans were getting air gun immunizations. They weren't necessarily changing out the needle or the syringe in between immunizations. So kind of depending on which screening recommendation you want to follow, that's the exposures I would consider. Also, if you have a patient that's preparing for PrEP, you may want to consider testing. If you know that there's unexplained chronic liver disease or hepatitis, even ALT elevation in a patient, go ahead and consider viral hepatitis testing, as well as solid organ donors and solid organ transplant recipients. Also, children that are born to Hep C positive mothers, which sometimes we don't necessarily have all of that information, but if that's available to you, you may want to screen those. You do want to screen those children as well, particularly if the risk factors were prior to the children being born. Next slide. So next step is really trying to establish, okay, the chronicity of infection. So what's their timeline of exposure history? My approach with this, is first trying to identify the known exposures that you can come up with. And then I also kind of ask them to give me a time frame. You know, when's the first time that you ever injected? When's the first time that you snorted? When's the most recent time? Because if somebody's only been I'm using injection as an example, but if somebody's only been injecting drugs for maybe a year, I wouldn't suspect them to already have advanced liver fibrosis, where someone that has more remote risk factors or has a longer period of risk exposure, I'd be a little bit more concerned that we need to consider more advanced fibrosis in those patients. And also assess for the risk for ongoing exposure to modify follow-up testing. We usually do a hepatitis C antibody. This is typically present within 8 weeks of an exposure. Kind of the caveats to remember here are HIV positive patients and also patients on hemodialysis may not develop that immune response, so they may not develop an antibody. You also, if you have a reactive hepatitis C antibody, then want to do the confirmatory PCR testing. In patients that have pretty significant transaminitis, particularly in the setting of an acute hepatitis picture, it's important to kind of trend that over time to see if they may spontaneously clear. So usually spontaneous clearance, if they are going to clear the hep C on their own, it happens most often in the first 3 months. Generally, we kind of give them 6 months time to clear before we consider them chronic, but do understand that some patients can clear up to 2 years. I recently had a young female that I was kind of following her over time. She wanted to be pregnant. I had considered her chronic because she had a viral load for 6 months. She kind of fell out of care, came back in a year and a half later. Viral load's been undetectable consistently now. So it can happen, not as often, but there is still a chance of clearance after that 6 months. Also, kind of symptom-wise, really only about a third of patients actually present with symptoms of acute viral hepatitis. It's usually about 8 weeks after their exposure, but can be up to 26 weeks. That's the whole jaundice and dark urine and myalgia, sometimes fever, arthralgias. But basically, when people present with that robust of a presentation, it actually maybe can guide you that they probably are going to spontaneously clear. But 2/3 of the time, they really don't have any kind of symptoms that clues you in as to when their exposure was. Next slide. So, what to educate your patients? A lot of patients come in really anxious with a new diagnosis of hepatitis C. They think that they're in liver failure and they're going to die right away. And so it's really important to educate that the natural history of hep C infection is really decades, not days, for significant liver damage to occur. That's really in the absence of confounding factors that can also progress liver disease, which we'll talk a little bit later about. But generally speaking, the risk of developing cirrhosis is anywhere from up to about 25% of patients, but it's really over a period of 20 to 30 years. And I kind of follow the rule of thirds. So of those that are infected, a third will not develop any liver disease, a third will develop more chronic fibrosis, and a third will develop cirrhosis. Next slide. You also want to educate your patients. Really they shouldn't be donating any blood or semen after they've tested positive for hepatitis C. Kind of discussions as far as transmission to household contacts. A lot of patients are fearful that they're going to transmit this to their children or grandchildren or even pets. Some people ask, I don't know, but so just tell them, really avoiding sharing personal equipment. I had a patient that said they were worried about giving it to their dog, but they didn't care about if their husband got it. So anyway, but they're not going to give this to their pets. But just kind of avoiding things like toothbrushes, dental devices, not sharing razors, nail clippers, scissors. Cover any bleeding wounds until they're healed over. And then the hep C virus, I get this question a lot. It really can survive on a surface for up to about 3 weeks. If there is an overt blood spill, so if there's visible blood on a surface, it should be cleaned with 1 part bleach to 9 parts water solution. But as far as just general household cleaning, just do that. I mean, if there's not visible blood on the toilet seat or on the sink or in the shower, they don't need to do anything special than what their routine cleaning is. And then also making sure that they're, getting legit tattoos. Greg Peters knows a lot about this. Next slide, please.
Don't say it quite like that. Like it's
not from personal, well, maybe from personal provider patient experience.
It makes it sound like I've got prison tats.
You have this side business. Also, for our patients that do, use drugs, particularly intranasal and injection, just really counseling them that if they're not cessating drug use at this time, really safer injection practices, not reusing or sharing their syringes, needles, even cotton, water, spoons or their cookers. I mean, any part of those work. Same with snorting straws or dollar bills or tutors. I mean, they really shouldn't be sharing any of that because those are a means of transmission. And a lot of patients know about the needles but don't necessarily consider the additional sharing of works. Sexual transmission overall is, not really great at sexual transmission. I would kind of say the caveat to that is the more sexual partners they have, or maybe the circumstances. So those that are paying for sex or those that are being paid for sex, I would consider Hep C testing maybe more often than just that one time with sexual practices. But usually, it's about 2% risk. HIV infected persons, especially men who have sex with men, really recommendation is for annual hepatitis C screening. And then also just remind them, if they're not monogamous, they should be kind of, using protection. But I generally tell patients if they're in a monogamous long-term relationship, heterosexual, they really don't need to change their current sexual practices to avoid transmission. So just to touch on HIV in the setting of drug use, often it's really the patient's addiction that causes the most harm, more harm to them than the hepatitis C themselves. And this is a good point to bring up with your patients because they get so fixated on the hepatitis C when they're not addressing the underlying issues that led them there. So hepatitis C was the leading cause of death. The leading cause of death in patients with Hep C was really not from their liver-related illness, but 72% of deaths were from drug overdose or suicide. Active drug use is not a contraindication to Hep C treatment. And again, remember the spectrum of addiction, it doesn't mean that everybody that's using drugs is addicted. Some people use recreationally, some people use during periods of stress, some people are dependent, some people are addicted. So it's really a case-by-case assessment. There is more data coming out that, really active addiction, even with drug use, they still have the same or very similar success rates with treatment. But the issue is that you may need to bring them in more frequently to assess compliance. Also payer restrictions. So in West Virginia, our restrictions are they have to be 3 months drug-free with the exception of marijuana before they'll be considered for treatment. And then more importantly is also assessing their reinfection risk. So if you're able to get them treated despite their active addiction, you have to make sure that they understand how to avoid getting reinfected because likely they will not have much luck getting a second treatment course in the foreseeable future. Next slide. So the clinical manifestations, usually asymptomatic. Most common complaints are fatigue and then also sleep disturbances, which it's really hard to weed out if this is from your hepatitis C or something different. Sometimes nausea, anorexia, myalgias, arthralgias, abdominal pain. Patients also complain of some neuropsychiatric effects, so depression and anxiety, as well as sometimes a brain fogginess, which really there's not a test to kind of differentiate this from something else other than you get their Hep C treated and they feel better. Some patients that present with the a lot of patients kind of think that they don't have issues from Hep C because they're associating it with cirrhosis. So A lot of times patients won't present until later into their course because they say, well, I never had any jaundice, so I just thought it was inactive. So some patients do present with the signs and symptoms of cirrhosis, but most of the time it's not symptomatic. We need to also be mindful that there's also a lot of associations with extra hepatic manifestations. So honestly, up to near 40%, about 38% of patients, smaller studies have said really do have some type of extra hepatic manifestation. Basically involves every part of your body system. So we need to consider mixed cryoglobulinemia, porphyria, leukocytoclastic vasculitis, sometimes glomerulonephritis, lymphomas. There's an association with diabetes, and then also autoimmune disorders. It's hard to have a direct correlation, but there have been a lot of associations with these manifestations. Next slide. So considering assessing for co-infections, because this can certainly progress liver fibrosis, making sure to screen for illnesses that share similar transmission mechanisms like hepatitis B, HIV. High risk behavior kind of prompts more infection, so maybe considering syphilis or even STI screenings at the first visit. And then also consider hepatitis A. We have had, again, an outbreak of hepatitis A in West Virginia, and a lot of it started with the injection drug use population sharing the same water source, or a lot of our transient patients that don't necessarily have stable housing and hygienic practices. But I would recommend going ahead and screening that first visit and then getting vaccinated if they're not immune. Next is assessing for liver fibrosis. So remember, the goal really is to establish the degree of liver fibrosis in all of our hepatitis C patients, not only just because the risk of related morbidity and mortality increases with the severity of fibrosis, but it also can kind of interfere with or change our management and Hep C treatment. This also helps determine who needs screened for hepatocellular carcinoma and varices. Typically, we utilize multiple modalities to really stratify this risk of disease progression. A solitary modality really isn't sufficient. Clinical judgment really isn't sufficient to assess for liver fibrosis unless you already have clear cirrhosis or even decompensated cirrhosis. So again, history comes into play, so their timeline of exposure risk. Also, exam findings, if they really do have advanced decompensated disease, you may start seeing the ascites and jaundice, encephalopathy, even some peripheral stigmata. Testing, your serum biomarkers can give you clues as to advanced fibrosis, liver elastography, basic CBC if you're seeing cytopenias. If INR is elevated, there's renal dysfunction, co-infections, low albumin. I mean, these are all clues that say this is, can be pretty advanced. Liver biopsy is still technically the diagnostic standard, but since it's invasive, it's not typically done in the setting of HCV alone. I've never ordered a liver biopsy on somebody in the setting of just hepatitis C. Some calculations that you can do just on your basic lab panel, and we'll go through the tests on a different slide, but APRI index, so this is your AST to platelet ratio index. You can get drug calculators, but it's basically the AST divided by the normal AST value at your reference lab divided by the platelets times 100. And anything over 0.75, there's a pretty high suspicion for more advanced fibrosis, and certainly above 1 is pretty not reassuring, but pretty concerning that there is advanced fibrosis. Fib4 is another calculation you can do, but it has square roots and I don't ever know how to do it, so I plug it into a calculator. But I believe it's above 3 if Fib4 is above 3. Next slide, please. So regardless of whether you're doing a liver biopsy or a non-invasive modality like a serum biomarkers, FibroTest, FibroSure, or our FibroScan or elastography, they're really still typically using the Medivir system. So calculates what we call your F score. And I won't go over these ranges individually, but basically, you know, if you have an F3 or F4, that's when we're concerned about needing to have ongoing testing and more advanced fibrosis. So factors that increase the rate of progression, certainly HIV or Hep B co-infection, alcohol use. I tell patients that if you're drinking alcohol regularly, it's like pouring gasoline on a fire to a liver that already has Hep C. And they tend to get that analogy a little bit better than just telling them don't drink. The older that you are when you become infected tends to have faster progression. Things like fatty liver, obesity, diabetes can progress your rate of fibrosis. Men tend to have a faster rate, and also postmenopausal women. So estrogen is a bit of a protective factor at delaying fibrosis, but postmenopausal women, you may want to consider faster rate. Vitamin D deficiency as well. Next slide, please.
Did I skip 2?
No, I don't think so.
Okay.
I don't know.
All right. We'll figure it out.
I'll figure it out if I don't talk about something. So just a point about alcohol. Really, a safe threshold of alcohol consumption hasn't been established. My approach historically has been, if I have a cirrhotic patient with hepatitis C who drinks, I'm much more harping on them that they really have to stop drinking in conjunction with hepatitis C treatment, you know, because if they're still drinking, it's really not going to make much of a difference. If it's somebody that's, you know, in their 20s, no fibrosis, drinks every once in a while, I certainly tell them it's probably not in their best interest, but I'm not harping as hard on them that they have to completely avoid alcohol forever. Prescription and over-the-counter medications usually don't require a dose adjustment. A lot of times patients are counseled they can't have any Tylenol at all. You know, generally speaking, if their liver enzymes aren't, you know, through the roof, they really can take Tylenol, just not more than, I'd say, 2 grams every 24 hours. So about half of what the recommended daily dose is for the general population. NSAIDs should certainly be avoided in all of our cirrhotic patients due to the risk of GI bleeding. And then also just kind of remember to ask about herbal and alternative therapies as well, not just prescribed medications. So vaccinations, so for anybody that's hepatitis C infected, certainly make sure that their hepatitis A and B vaccines are administered. A pneumococcal polysaccharide vaccine is also recommended for everyone with chronic liver disease, and this isn't necessarily because we're worried about pneumonia, because we always say, hey, you need to get your pneumonia shot. We're really worried about invasive pneumococcus, so like meningitis, bacteremia, which is why that's recommended. Certainly your annual flu vaccine, and then also the tetanus shot. So vertical transmission. Overall transmission for Hep C, it's about 6% risk of vertical transmission. There's really nothing that we can do to decrease this risk, but there are some factors that can increase the risk. So transmission rates increase to about 10% if HIV co-infection is present. Also, if they're active injection use, and we don't really understand why, but active injection also has increased vertical transmission risk, particularly if they're infected during pregnancy. We also tend to tell people to, if possible, try to avoid invasive procedures like scalp monitoring. Some even say even amniocentesis during pregnancy if possible, because that may increase the risk as well. In addition, if your viral load is over 10 million, there's also a little bit higher risk of transmission. But again, there's nothing we can really do to decrease that risk. If a patient's planning treatment and pregnancy, just remind them there's really nothing available that's approved yet during pregnancy as far as Hep C treatment. There's a study, but there's a study actually in Pittsburgh where they're treating pregnant women for Hep C, but there's really not, you know, obviously it's a small number. And I think they're doing Harvoni, I think with 8 weeks or 6 weeks. But right now there's nothing approved. So recommend that really females of childbearing age are screened for pregnancy prior to initiating treatment. And then I've been doing monthly screenings on them too whenever they're on treatment as well. A lot of times if they become pregnant and they're already on treatment, they're going to be almost done by the time they find out anyway, but it's just something to kind of be aware of, so you counsel them. If they're on treatment, they should avoid breastfeeding, because we don't know how it's excreted or what the transmission risk as far as the medication excreting through breast milk. But if they're not on treatment, they can safely breastfeed. So as long as a mom is not breastfeeding and there's not any kind of cracks or fissures in their nipples, if that's the case, they really should be nursing on the opposite side, and they'll probably have to just pump and dump until that is healed over. But there's not breast milk transmission risk, more so the blood transmission. So lab work, CBC, liver panel, renal panel, your lights, hepatitis C genotype, which is becoming not as necessary now since we have pan-genotypic agents, but at this point they're still, recommending this if you believe that it's going to change your management. And since there's some genotypes that can progress faster, I tend to get this on all my patients if possible. Your Fibro test or FibroSure, which is your serum biomarker, and again, that measures multiple enzymes and then kind of plugs it in an algorithm and spits out an F score. HIV, hepatitis A, and Hep B serologies. And remember, not only are we checking your surface antigen, but your surface antibody and also the hepatitis B core total antibody to really see if there's been any history of hepatitis B infection, because of the fact that if you're doing treatment and they have had prior exposure but have not developed immunity, there's a risk for Hep C or Hep B flare on treatment. Checking vitamin D, a UA. You might want to consider doing cryoglobulins and rheumatoid factor if you have any suspicions. Iron studies, autoimmune hepatitis screening. Urine tox screen, that's really at your discretion. I don't do it on everybody, but I do kind of utilize it sometimes if I think it's going to affect their compliance or their follow-up. And then pregnancy screen. Okay, and then when you're planning for treatment, again, introduce kind of the concept of treatment. So, back when there was interferon, some patients really have a lot of fear that they're going to they've heard about a friend that went through Hep C treatment and they felt it was chemotherapy. And so if a patient's kind of hesitant about treatment, really try to investigate why. Because these direct acting agents they directly target the virus itself. They're not going to affect the immune system like interferon did. And that's a lot of times patients' hesitation for starting treatment. Make sure you're defining if they've had any prior treatment, because if they've been treated in the past, so with interferon or ribavirin, or even have had direct acting exposure, it's going to change your duration and maybe your management of therapy. Again, assess barriers to treatment, so such as compliance, financial, and then also social factors. So pending legal charges, housing stability. You really want to make sure that when they're getting treated, they're going to be successful. And so taking those into consideration, certainly drug and alcohol counseling, and also considering drug interactions. And then some references, HCV guidelines, that's our Bible. If you ever have any questions, just go there. And that's it.
And thanks, Kaylee. The only thing I was going to mention is, Kaylee mentioned about the genotype kind of losing its power of us, the importance of checking at the pan-genotypic age. One of the utilities that I've still, it's I think come up once or twice when we've had a person with infection again. Mm-hmm. It's nice to know what their original genotype was, so that you can sort of label them a new infection potentially or a treatment failure. Mm-hmm. So we've had one guy who had genotype 1 and then had what we were calling a relapse or a failure, but then turned out he had a genotype 3 the second time around. So even from like an epidemiology standpoint, sometimes checking those genotypes is helpful.
Thank you so much, Kaylee, for that. We unfortunately are out of time. I was just going to quickly read Craig's comment. He mentioned that as a risk-based decision to screen, you might consider living in an endemic region or risk factor. That's how he thinks about it, and that's what we could certainly qualify. And I know there are some questions out there based on Kaylee's didactic, so any questions you all may have, please feel free to email me. My email will be in the recap that I will send out later today. So I apologize we did run out of time, but thank you, Kaylee, for the didactic and Jenna for the wonderful case presentation. I just have 2 announcements really quickly. So our next session will be on January 23rd, and Dr. Gail Fuss will be presenting the didactic on HCV HIV co-infection overview. And Milena Bernstein, she's going to be reaching out to the participants in this ECHO project just to see who would like to be involved in an evaluation and publication for Project ECHO. So just to be on the lookout for that during the next session. And if there are any questions, please don't hesitate to email me or Caitlin. But all right, thank you all so much for joining. This was a wonderful session as always. Have a great day. Thank you, bye.
Hey, John, before you guys cut out,
Yeah.
I'm instant messaged Caitlin. I just wanted to touch base with you. I'm going to hit you up to speak at the WVAPA conference.
Cool.
It's
When is it?
Mother's Day weekend. It's in May, first weekend in May.
See, the water's running by then, so yeah. Southern part of the state, I should do some. I can bring a kayak.
Yeah, there you
Cool.
go.
All right, I'll make sure to get her a message to you, and then we'll try to get you first dibs on a time.
Cool. What do you want to talk about? Lyme disease or?
Anything? Yeah, Lyme's one of my favorites, but whatever you want to talk about is great.
Antibiotic stewardship. That's my latest. So.
Yeah, that's cool. Listen, you can speak half the day if you want, as far as I'm concerned.
Wow. Open mic. It's great. You don't want that.
Cool. All right. Thanks a
A lot of
lot.
disclosures on my end.
Thank you.
All right.
Thanks, guys.